So here we go. How to avoid surgery for urinary incontinence. What we're going to do is start by talking about common surgical therapeutic options and really what they entail, their success rates, and what you have to go through if that's something that you're embarking upon. And then we're going to talk about some things you can do to avoid surgery. Most people can do this successfully. And I'd encourage you to look at these things, talk to your doctor about them. And I think you'll find that if they're not bringing it up, but you are, they will allow that these are reasonable alternatives to surgery. And with respect to the pelvic floor fitness solution we'll discuss, your doctor may not be aware of Pilates. You may not be aware of Pilates. It's Pilates. You can find it at Pilates.com. And I think that if you educate your provider, they'll say, yeah, that sounds like a really good option for you. And I think by the end of this video, you'll know that if you embark upon it, you'll probably be successful. So these are encouraging facts. So I always say that urinary incontinence is a fitness problem. And of course, that implies that there is a fitness solution. You know, the prevalence, how common urinary incontinence is really kind of hard to pin down because the data is a little bit soft. It kind of depends who you ask, how old they are, how many kids they've had, what their baseline pelvic floor fitness status is, how strong the pelvic floor is, how fast the pelvic floor is. All of these things matter. And so you have this like crazy range of data when it comes to the prevalence, how common it is in our society. Some people would only record someone as having incontinence if it represents a moderate or major quality of life problem. And others would say, no, any leakage with physical activity or concern about making it to the bathroom quickly enough suffices to define someone as having urinary incontinence. And so you don't need to get hung up on the exact number because there isn't an exact number, but rather just understand this is incredibly common. And it's more common than you think. In fact, if you disclose this condition to people you know, you'll be shocked to find out how many of your friends and colleagues and family members also are dealing with this problem. So it's super common, but does it have a significant impact on quality of life? Well, it for sure does. Now, this has been well studied, and we know that it has an impact on mental health, sexual health. It has an impact on physical health in terms of one's predilection for urinary tract infections or vulva conditions, infections, things that might cause you to want to see your doctor. And so the issue is incredibly relevant, incredibly important. You need to know what all of the options are, not just let's put you to sleep in the operating room and implant permanent synthetic mesh. Although that procedure is safe and it's highly effective and minimally invasive, and these are all great things, but I think we need to kind of begin this discussion with a statement of fact that if you can avoid going to sleep in the operating room, you should probably avoid going to sleep in the operating room, right? I know that I would try to avoid it if I could. Now, its impact economically is also significant. I was looking for the most recent data I could find, and the best I can tell you, in the United States alone, this condition, bladder control problems, is responsible for over $80 billion annually. And that includes continence products and medications and doctor's visits and lost work. All of these things, I think, are pretty convincing evidence that from an economic standpoint, it is of high significance. And from a personal health standpoint, it is also of high significance. And just from a mental health standpoint alone, we know that living with incontinence, not addressing the issue, leads to social isolation, but I think it's the degree of healthcare isolation, the embarrassment or the incorrect understanding that this is not an inevitable part of childbirth and aging really needs to be brought into the foreground so that, we can say, no, this is a fitness issue that for most people represents poor conditioning, strength, and speed of the pelvic floor, and that there's a lot you can do about that. Right. So this slide is really meant to orient you as to kind of how the workflow of a doctor's visit addressing this problem is likely to go. Maybe not exactly, but in general, this is going to give you an idea of what to expect. And one of the first things your doctor should ask you is, how much of a problem is this in your life? Is it a minor problem, a moderate problem? Is it having a major impact on your quality of life? And they'll use that to decide, how aggressive they want to be or want you to be about treating the problem. And they probably also ask, how long have you had it? Has it been a week or a month or many years? Has it been stable, not getting worse, or has it been getting worse? And the fact is that if it presently is a minor issue for you, it's probably not going to get better long term without you doing something, right? And there's a high probability it's going to get worse. And so it's a good idea to address these things with a conservative solution if it's currently a minor issue, to avoid it becoming a moderate or major issue that is, of course, more likely to result in some kind of invasive procedure, like one of the slings procedures we were talking about in the last slide. And Medicare requires the doctor to document if you've tried Kegel exercises for a month without benefit. They have to write it in the chart if they want to be reliably reimbursed by Medicare for doing a surgical procedure. So they're probably going to ask you about that. And the fact is, believe it or not, Kegel exercises do work if you do them. Now, patients, and this is based on 25 years of clinical experience, are not great with going home and just doing Kegel exercises and becoming successful in terms of relieving their incontinence symptoms. So it's really not enough just to say, go home and do some Kegel exercises. You need to have more understanding of why pelvic floor exercise is effective, and you need a more efficient way of performing pelvic floor exercise to really get the results that you're looking for. But they're probably going to ask, have you tried doing Kegels? And they're probably going to want a urine specimen. They'll want to make sure you don't have a bladder infection or other problems that could be causing incontinence that don't represent true stress urinary incontinence. And they'll do a physical exam as well. Now, hopefully, they'll document something about what the status of your pelvic floor muscles are. This is usually done during a bimanual exam where the doctor has one or two fingers inside the vagina while asking you to contract the pelvic floor muscles as strongly as you can. And then they hopefully would record, the pelvic floor muscles are weak or moderate or strong as they should be. And this can also help them make a decision as to whether or not the opportunity for improved pelvic floor performance is likely to lead to success in terms of relieving symptoms of incontinence without surgery. They may say one option is to go see a physical therapist and have so-called pelvic floor therapy, and that can be a very good thing. However, in my experience, lots of patients that say, okay, I'll try that, actually don't show up for the first visit. Probably more than half don't actually show up for the first visit. And there's probably a lot of reasons. You got to get in the car, you got to drive to the physical therapist's office, you got to make a copay every time you see them. And a course of physical therapy for bladder control problems is 6, 8, 12 visits. That's a lot of copays. People don't like doing that either. And a lot of the times physical therapists are using less advanced forms of pelvic floor rehabilitation. Now, traditionally, physical therapists have used electromyography to record with little sensors what the pelvic floor muscles are doing as they ask you to squeeze them quickly and then squeeze and hold the pelvic floor for several seconds. And then if a client, a patient, you use your abdominal muscles or your gluteal muscles or inner thigh muscles, they might stop you and say, no, you must isolate the pelvic floor muscles. Well, guess what? That is very difficult to do because it's not how you're wired. And the whole Pilates program is predicated on an understanding that we need to use these co-contractors of the pelvic floor, the deep abdominal muscles like the transversus abdominis, inner thigh muscles, and gluteal muscles to accentuate, to amplify the strength and speed of the pelvic floor. And so the reason it's so hard to isolate the pelvic floor is because it's not natural to isolate the pelvic floor. With this understanding, you can create a more efficient program, meaning you can make people better quickly. And when you're touting a fitness solution for a problem like this, you have to make people better quickly or you lose them. They give up. And our data suggests that 80% of our clients are at least 50% improved in 28 days of training. And that's usually enough to keep people on board and then convince them long term this is something that really needs to be incorporated into their daily life. It's not a huge commitment, but it has to be a consistent small commitment. 5 minutes in the morning, 5 minutes in the evening until you're better, and then maybe just 5 minutes once a day will do the trick. For most people, that's true. And so, as it would typically go, is like, okay, go home, do your Kegels. And you say, I tried that. Or maybe you go home for a month or two and you take a stab at it and then come back and say, oh, I still have the problem. And they send you to the physical therapist. And maybe you go, maybe you don't go. But regardless, you come back and you still have the problem. Well, then the doctor says, well, I tried not operating, and so now let's talk about getting you scheduled for surgery. That would be a typical progression of the healthcare process when it comes to addressing these problems. So if you get to a point where you're talking to your doctor about surgery, it's good to know what to expect in terms of what surgical procedures are recommended, available, tried and true. And by far the most common modern surgical solution for treating stress urinary incontinence, leakage with coughing, sneezing, laughing, exercise, is the current mid-urethral sling. And it really is quite a good procedure. I've done well over 5,000 of these procedures over the course of my career, many fewer since developing the Pilates method of pelvic floor fitness training. But nonetheless, I have a great deal of experience with this procedure. I've seen complications, although they're not super common. There are a few percent of people will have problems afterwards that need more medical attention. That doesn't mean that they're permanently debilitating, although anytime you implant surgical mesh in the body, there's a possibility of creating, for instance, pain problems, painful intercourse or groin pain, that even if you remove the mesh can still be an issue. So it's important to be aware of that. Some of the procedures that were used more commonly before the modern mid-urethral sling was developed in the late 1990s are like the pubovaginal sling. It is a more invasive procedure, but was effective. The Birch procedure, which in the old days used to be done through pretty good sized abdominal incision and then was accomplished with a laparoscopic approach, little Band-Aid surgery approach. There are office procedures like urethral bulking, where they inject a material that doesn't go away, hopefully, around the urethra to kind of force that urethra to just be more closed all the time. The data on long-term effectiveness of urethral bulking has been not great. And I have never personally been a fan of this as an office procedure, but there are still docs that do it. Over the last decade or two, radiofrequency procedures that can be done in the office have been defined with mixed success. And then this whole vaginal rejuvenation thing came about, and it's kind of softly suggested to patients that this will restore continence. I've not seen great data on that, and it's very expensive. Insurance doesn't pay for it. Many thousands of dollars to have this done. And so if incontinence is the main problem and resolving it is your main goal, probably having laser vaginal rejuvenation is not the first thing you want to try. So, like I said, if your doctor offers a surgical solution to this problem, they're probably going to offer a midurethral sling. And there's a bunch of companies that produce kits that the doctor would then use to implant this piece of mesh through a small incision underneath the urethra. The mesh is made out of polypropylene. It's typically a knitted, very thin, lightweight, small piece of mesh. It's usually done through 3 small incisions, one on each side of the vulva, and then one inside the vagina, right under the urethra, and they work remarkably well. The success rates for these procedures are probably in the 80% range, just about the same as if you try Pilates for 28 days. But any surgical procedure has risk. I always say the definition of major surgery is when it's on me. That's a major surgery. And even with a relatively minimally invasive surgery, you can't escape some finite risk. Anesthetic risks alone exist. They're not common, but if it happens to you, it doesn't feel rare. Mesh complications can affect a small percentage of patients that have these procedures done, sometimes requiring the mesh to be trimmed. Usually this can be accomplished in the office. Sometimes you have to go back to the operating room to cut out a piece of mesh that became exposed to the inside of the vagina. After surgery, pain complications, painful intercourse in particular, for patients that have had this done, but also, if there's mesh exposed, their partners can complain of pain problems during intercourse because that exposed mesh would be very scratchy. And so sometimes that's a reason for having the mesh trimmed or partially removed. Infectious complications are really rare after this procedure, but when they occur, they're kind of a big deal. There have been rare instances of an infection tracking into the groin and causing something called necrotizing fasciitis. Look it up if you want to be scared, because it's a terrible thing and dangerous and requires rather extensive surgical treatment. Fortunately, very unusual. Very unusual. And then, of course, anytime you have surgery, there's going to be some risk of bleeding. The transobturator procedure, or TOT, which is probably the most common approach to the midurethral sling, has a very low risk of bleeding complications, very low risk of bladder injury, urethral injury. Not zero, but low. The original midurethral sling, which was called TVT, or transvaginal tape, or tension-free vaginal tape, actually required you to place the mesh behind the pubic bone and then out through small incisions made just above the pubic bone. And bleeding complications were a little bit more problematic with this procedure because there's a lot of big veins in that area. But for most patients undergoing a sling procedure today, a transobturator approach would probably be elected. And bleeding complications would be extremely rare. But not zero, and if it's you, it doesn't feel right. Right, so what can you do? Let's get down to sort of why you decided to watch this video in the first place. Give me something I can use. And hopefully this will impress upon you the fact that there are lots of things that can be done. One of them is probably more important than any of the others. And so starting at the bottom of this slide, there are things called pessary devices, which are these silicone discs or oddly shaped objects that are worn inside the vagina. And they have been used mostly to treat prolapse, but they have been used for patients with stress urinary incontinence as well, by placing a little more pressure on the bottom of the urethra to kind of help it stay closed when you're coughing, sneezing, laughing. Not a real effective solution. And even for prolapse patients, the vast majority of patients that use pessary devices, probably only 10% of patients that try a pessary continue to use it long term. So there's a tolerance issue for sure. Topical estrogen can be effective and is a pretty good, reasonable, conservative option. A lot of patients, remain very concerned about the risks of using any form of estrogen, and I think some of this stems from all of the media attention that the Women's Health Initiative study got, over 2 decades ago now. The fact is, topical estrogen cream, for instance, applied inside the vagina as a little blueberry-sized bead twice a week, is not the same as taking estrogen orally or applying an estrogen gel or wearing a patch, because a very minimal amount of estrogen gets absorbed systemically into your body when you use topical vaginal estrogen. And so the risk profile is different, even though the FDA kind of requires you to put the same risk warning information in the package insert, so it looks like, wow, dangerous and scary. Probably not. And for most people, it probably is a good solution. Now, patients that have had a history of breast cancer, I still tend not to use it. I'm not convinced that I haven't seen evidence that shows use of topical estrogen in a patient with a history of breast cancer increases their risk of recurrence or of a new primary breast cancer. But they're so sensitive to the possibility of having to deal with that, and their oncologists freak out if you prescribe topical estrogen, so it just doesn't happen for those patients. But for most people, it is a great option after menopause generally, when your ovaries aren't producing estrogen the way they used to, and the vaginal tissues in particular are greatly affected by chronic low estrogen levels, and you can replace that topically, and it is safe. Weight loss, even as little as 10%, if you are starting overweight, which most of us are, unfortunately, even losing as little as 10% of your body weight can improve or resolve stress incontinence. And so, that's certainly a noble effort, hard to do and maintain for sure, but it's worth mentioning. Pelvic floor exercise, though, is something you can do. You can start today and start getting your pelvic floor working better, working faster and stronger. And this is a safe and reliable way of addressing an incontinence issue without medication, without cutting or mesh or any of those things. Like, why wouldn't you try that? The fact is, not everybody's going to pick up a fitness solution, but everybody should be offered a fitness solution. It should be at least presented to them as a reasonable thing for them to try in at least the initial stages of addressing this problem with a doctor. And so I'd encourage you to do so. Right. So let's talk even more specifically, without being overly redundant, about this Pilates method. This was a method created, back 2009. I guess it has evolved as all processes do. We've certainly gotten better at administering this program. As I mentioned, our clinical data shows us that 80% of patients are at least 50% improved in 28 days of training. One interesting fact is, we've recently started licensing this program to senior adult residential facilities. And so we moved it from a purely medical clinical environment where the program was taught and encouraged, and patients would be seen back after several weeks, to a fitness environment where they have more follow-up with their instructors. And the instructors are all trained by us. And what's interesting is the success rates seem to be exactly the same as when it's administered through a healthcare setting, through a medical setting. Really encouraging. And this is a population of people that you might think are less inclined or less likely to be successful with a fitness solution. They're old, right? Not true. And in fact, the way Pilates is taught now really accommodates all levels of ability, even if you can't stand. There are modifications of these movements that you can use that should work. And so, we used to teach everybody to do all 10 Pilates movements. We don't do that anymore. Now we help people to discover which of the 10 are their best movements and just pick 2, but no more than 3. And those are the movements that they would use 5 minutes in the morning, 5 minutes in the evening, until they're better. And usually, as I mentioned, that's pretty quickly. So there's no devices or equipment. You don't have to insert anything in the vagina. It's something that can be done anywhere at the gym. Incorporating it into a regular fitness routine makes a ton of sense. And so again, that kind of helps this program be accessible and efficient for the general population. And the fact is also, and we don't talk about this enough, but this program is suitable for both men and women. Men have pelvic floors too. I joke that the only group of people less informed about the relevance of the pelvic floor than women is men. They, however, also experience pelvic floor disorders. Overactive bladder is just as common in men as it is in women. Erectile dysfunction is extremely common and is very important to men. A lot of men don't want to take a little blue pill. And the data on the effectiveness of pelvic floor rehab for erectile dysfunction is pretty encouraging, actually. And so, you might mention this to your significant other or spouse, and maybe embark upon a process of addressing what I call the last fitness issue together, right? This is something you can do that should enhance your quality of life and theirs. So the good news is Pilates is efficient, right? It works quickly. Pilates is effective. It just works. It's also accessible. One of the good things that came from the pandemic is that we had to create our services in a digital online platform, right? Because you couldn't, for a period of time, you couldn't get anyone to come to the office. And so that really led to this Pilates for $49 thing that we offer on our website for both men and women. It's a 2-hour webinar, but it's self-paced. You can start it. If you are like me and have a short attention span, you can stop it, come back to it. But over the course of a 2-hour program, you will learn the 10 Pilates movements. You'll use a movement selection worksheet to find out which your 2 best movements are. You'll get a schedule. You'll learn modifications. If you can't do the full movement, a way to do it that accommodates whatever functional limitations you may be dealing with. And it's affordable, only less than $50, right? And so being efficient, effective, affordable, and accessible were the 4 criteria that we have long held as the essential 4 criteria for creating a successful program for addressing this epidemic problem in our society, and I think we've done so. So maybe you're thinking, that sounds great, Dr. Crawford. What do I do? Well, it's pretty darn simple. All you got to do is go to Pilates.com, Pilates.com. And then right along the top of the screen there, you'll see Pilates for women, Pilates for men. Pick the right one, and scroll down and click on the Sign Me Up button, and it'll take you to the enrollment page, and you can get started like literally right now. And again, it's a 2-hour process to learn the technique, and then you must do it. Right? Doesn't work if you don't spend the 5 minutes in the morning, 5 minutes in the evening. Diligently make the commitment. I'm going to try this for 28 days. What have you got to lose? Well, $49. But I think that for most people, the idea that this may well resolve a problem that could result in surgery makes that an affordable option. And so I'd encourage you to give it a try. I hope this has been interesting. I hope it's given you some practical information that you can use. I wish each and every one of you the best of luck. Give us some feedback. Let us know in the comments what you think. If you try Pilates, come back to this video and make a comment. Let us know if it worked for you. We continue to evolve the program. We're always getting better. so that we can make you better. All right. Thanks, everybody. I'll be in touch too.